Good afternoon, everyone, and welcome to Medical Grand Rounds. Just a reminder before we get started that you can just enter your questions in the chat at the end of the presentation, and if you can please answer a brief survey that will be sent to you once again at the end of the presentation so that we know that you were present today. Our speaker today, Dr. Daniela D'Agostino, is brought to us courtesy of the Division of Medical Genetics, and we have the Chief of the Division of Medical Genetics, Dr. Bettina Mucciolini, who is going to introduce our speaker. Bettina, thanks for being here and introducing our speaker. The floor is yours.
I want to thank Dr. D'Agostino for giving the presentation today. So it's my great pleasure to introduce my colleague. Dr. D'Agostino has been very important for the community of patients with neurofibromatosis, not just at our institution. She's very heavily involved, not just here with the clinic, she sees both adults and children, but also as a member of the scientific advisory committee of the Association de la Neurofibromatosis du Québec. She's a contributor to the International ClinGen NF1 Variant Curation Expert Panel. And she's also a principal investigator of the COMET trial, which tests selumetinib in patients with NF1 here at the Glen site. So you really have a renowned expert here on neurofibromatosis to tell you more about this condition and why you should know about it. So without further ado, enjoy the presentation.
Thank you for putting no pressure on my shoulders, Bettina. Anyways, I'm gonna share the screen. That's step number one, and then we'll start the presentation. I just want you, if someone can confirm that you can see my screen.
Yes, it's all good. Thank you very much.
Perfect. Okay. So good afternoon, everyone. It's a pleasure to be here to contribute to this meeting today. I will update you on what keeps us busy in the field of NF1, including its management and research directions at the MUHC. I have about 70 slides, and my presentation will last about 45 to 50 minutes. I wish to state that, sadly, I have no conflicts of interest. A few words about the NF1 clinic at the Glen site. The pediatric component was founded about 30 years ago by Dr. Ortenberg. In 2016, we created a component dedicated to the care of adults with NF1. The clinic works as an ongoing diagnostic service, receiving regular referrals from multiple sources, including primary care physicians and specialists such as dermatologists, neurologists, and oncologists. It runs twice or 3 times per week and currently follows more than 500 active NF1 patients for all aspects of their health. In addition to the Glen site, a sizable pool of NF1 patients are followed up in neurosurgery at the MNI, primarily by Dr. Eber-Blouin. As MDs leading these clinics in true adherence to the MUHC mandate, we strive to provide patient-centered, whole-person and multidisciplinary care to patients with NF1 across all ages. For those interested, an additional source of information on how our clinic operates can be found in the last summer issue of Chez Nous, available on the MUHC portal. This is one of our families where a mother and their son have NF1, and their history is featured in the article. This is the primary team of the clinic, Dr. Ortenberg and Dr. Eber-Blouin and myself. Since last summer, Ms. Marie-Josée Guy, a nurse clinician, also joined the team on a part-time basis. Dr. Eber-Blouin and I estimated conservatively that as a whole, the adult component of the MUHC NF1 clinic is currently 400 patients strong. It receives up to 10 referrals per week, so it's growing in size. And as expected from genetics and epidemiologic data, about half of the patients are females and half have the familial form of NF1. Also, the genetic background of our patients reflects the panethnic nature of NF1 and is a testament to the diversity of the population served by the MUHC. The objective of this presentation is to review concepts related to the pathogenesis of NF1 and to the clinical course and management of patients with this tumor predisposing syndrome, with focus on aspects of precision medicine, including emerging genotype-phenotype correlations, clinical trials, and research trends. We'll do that by tackling the following NF1-related aspects: general concepts, molecular basis, pathogenesis, and complications of NF1, basis of clinical variability of the syndrome, management guidelines, and future perspectives. So neurofibromatosis type 1 is a multi-system condition that occurs in 1 in 3,000 individuals. Inheritance is dominant, and as a result, each child of an individual with NF1 has a 50% chance of inheriting the disease. NF1 is the most common hereditary tumor predisposing syndrome, and patients with NF1 require lifelong proactive clinical monitoring. As such, a diagnosis of NF1 has a tremendous impact on the psychosocial well-being of patients. If we consider the amount of patients, the size of the population of patients we follow, we can infer that about 25% of the NF1 Quebec patients is followed, patient population is followed in our combined MNI Glen clinics. And the number is probably higher at the MUHC as a whole. NF1 may involve a variety of symptoms, and it manifests itself differently in different individuals. The major impact is on the skin, nervous system, and bone. The most common manifestations are skin caffeolus spots, that is, regions of the skin that are darker than the surrounding skin, axillary and inguinal freckling, multiple skin tumors called neurofibromas, either cutaneous or plexiform, optic pathway tumors, we can see here, iris hamartomas called leash nodules, and these are characteristic of patients with NF1, but do not alter vision, skeletal abnormalities, including scoliosis and long bone dysplasia, learning difficulties, and an increased lifetime risk for a variety of malignant tumors. The penetrance is complete, that is 100% of individuals with NF1 will show signs of the syndrome. However, the expressivity, that is the degree and the extent with which NF1 manifests itself, is different in different individuals, and this makes management challenging. The diagnosis of NF1 is primarily based on clinical assessment. The syndrome should be suspected in individuals who have any of the features listed above, and the diagnosis is established in the presence of 2 or more of these elements. These diagnostic criteria were developed by the National Institute of Health in 1988, and they've stood well the test of time. They're both highly specific and highly sensitive in virtually all adults with NF1. Children who have inherited NF1 from an affected parent can usually be identified within the first year of life because diagnosis requires just one feature in addition to a positive family history. And this additional feature is usually multiple caffeolus spots, which develop in infancy in more than 95% of individuals with NF1. However, diagnosis in young children without a family history of NF1 may be difficult because many features of NF1 manifest with age. I will briefly focus on some of the pathognomonic features of this syndrome. Caffeolus spots are the most common non-neoplastic manifestations of NF1. The typical caffeolus spots in NF1 are elliptoid with smooth margins, uniform in color, about 1 to 3 centimeters in size, flat and flush with the surrounding skin. Having up to 3 such spots is common in the general population. 4 is a gray zone, and 5 and beyond is highly suspicious of NF1. The probability of having 6 or more caffeolus spots in an individual with no underlying genetic disease is less than 0.1%. Many children with NF1 will typically have caffeolus spots by age 2, most certainly by age 5, and they will be fully penetrant by age 12. And sometimes they may fade in adulthood. The most common benign tumors in children and adults with NF1 are cutaneous neurofibromas, a type of peripheral nerve sheath tumors, and the defining features of the syndrome. Present in virtually all patients, neurofibromas may develop from early childhood to early 20s, increase during puberty and pregnancy, may have a purplish tinge and become pedunculated as they grow. They vary greatly in number between individuals and within families. They never undergo malignant transformation, but they often catch on clothing and cause cosmetic problems. They can also cause stinging and itching. And as such, they impact significantly on quality of life. Especially pruritus and irritation do not usually respond to medical treatment, and they can be removed if they cause any of the problems mentioned above, but sometimes they grow back. Plexiform neurofibromas are a distinct type of nerve sheath tumor arising from within one or multiple nerve trunks or branches. They come to attention early in childhood and are believed to be congenital lesions. They are found in about 50% of individuals with NF1, and about 25% will require an intervention. They can occur in any area of the body, including internal organs, and they may have overlying skin hyperpigmentation or a hairy patch, and may tend to have heterogeneous texture or nodularity on palpation. These tumors may be asymptomatic or can cause pain and morbidity, by compression or overgrowth of adjacent structures, especially bones. There is no universal agreement on the frequency or type of surveillance imaging of plexiforms, and indications for surgical resections of plexiform neurofibromas are neurological impairment, pain, and severe disfigurement, and the goal is usually to restore or protect function. They're usually difficult to remove in their entirety because of interdigitation into normal tissues and peripheral nerves and high intrinsic vascularity. Especially in children, we look carefully for atypical caveolé spots, such as those with unusual discoloration, or large caveolé spots that may betray the presence of deep-seated neurofibromas. And this is another example. So let's look at the molecular basis of NF1. The NF1 gene is placed on chromosome 17. And as you know, there are two alleles or copies of the gene, one inherited from each parent. In NF1, one of the two copies of the gene is disabled by pathogenic variant in keeping with dominant inheritance. The NF1 gene is unusual in that it's very large, containing coding sequences for at least 3 other genes. And also the mutation rate of the NF1 locus is one of the highest reported in any human disorder. This is reflected in the finding that almost half of all NF1 patients exhibit a de novo pathogenic variant. Neurofibromin, the gene product, is expressed in many cell types and function as a tumor suppressor. This means that NF1 patients harboring heterozygous NF1, heterozygous germline NF1 pathogenic variants develop clinical features such as, for example, caveolé spots and neurofibromas upon somatic hit or mutation of the second wild type NF1 allele. The complexity of molecular testing to identify pathogenic variants in NF1 is related to the large size of the gene, but also to the relative lack of hotspots for pathogenic variants and the diversity of the variants. A multi-step approach is then required with analysis of blood genomic DNA and complementary DNA, which is DNA copied back from mRNA, as well as testing for NF1 gene deletions. This strategy identifies more than 95% of causative variants. Testing can be performed on any source of DNA, usually a blood specimen, and most identified variants lead to loss of function of the gene product as expected for a tumor suppressor gene. NF1 gene sequence interpretation is bound, as for any other gene, by the guidelines set by the American College of Medical Genetics and Genomics. This report recommends the use of specific standard terminology to describe variants identified in genes that cause Mendelian disorders. And also this recommendation describes a process for classifying variants based on criteria using typical types of variant evidence, for example, population data, computational data, and so on. This standardized system not only facilitates use of the evidence provided by genetic testing for medical management, but it also facilitates genetic data sharing. This process is further refined by initiatives such as the NIH-funded CleanVar and CleanGen, which strive to increase knowledge about the relationship between genes and health, by, for example, creating gene-specific modifications to the ACMG guidelines, knowledge that can be used in precision medicine and research. One specific goal of CleanGen is to develop panels of experts to evaluate the clinical validity of specific gene-disease relationships and the pathogenicity of individual genetic variants. One such panel was created for NF1 this past fall with the goal to systematically review all available NF1 variants, ensuring they're listed and shared with the proper clinical annotation. The panel is organized in 3 main subgroups, and with over 3,000 unique NF1 pathogenic variants, it's expected that this work will last several years. Long-term funding of this collaborative work is being applied for with the Children's Tumor Foundation. So if we look at the pathogenesis of NF1, the product of the gene is a protein called neurofibromin. This protein is expressed in many cell types, and it functions as a negative regulator of the RAS proto-oncogene by accelerating the conversion of the active GTP-bound RAS to the inactive GDP-bound form. In this manner, loss of neurofibromin expression is seen in tumors associated with NF1 leads to increased cell growth and cell survival through the hyperactivation of RAS. RAS then transmits its growth promoting signal through the ACT-mTOR and MEK-ERK pathways, and also through the generation of CAMP. Depending on the cell type, RAS signaling might differentially use these downstream effectors, resulting in different cellular consequences. Virtually all clinical manifestations of NF1 may be explained by biallelic inactivation of NF1 and RAS pathway hyperactivity. For example, café spots consist of a dense population of melanocytes with biallelic NF1 inactivation, and cutaneous and plexiform neurofibromas are driven by NF1 inactivation in span cells from precursors at different stages of maturation in a permissive mixed cellular context and abundant extracellular matrix. And this is illustrated in this picture, where we can see more specifically the complex interplay between neoplastic cells, the Schwann cells, and non-neoplastic cells, macrophages, mast cells, and fibroblasts, which dictates the development and growth of plexiform neurofibromas. So we see this has been observed in mice. The secretion of KIT ligand by NF1 deficient span cells increases the proliferation and migration of NF1 mutant mast cells, which when recruited release transforming growth factor beta, promoting increased growth of NF1 deficient span cells and the establishment of a rich extracellular matrix. Other cells in the tumor microenvironment, such as, for example, macrophages or fibroblasts, may have active roles in tumor initiation or continued growth. Many individuals with NF1 manage well with support and education from local clinicians and their organizations. However, some NF1 patients suffer from rare diseases complications that are associated with significant morbidity and may be life-threatening. They range from severe cognitive problems to disfigurement and malignancy, including nervous system tumors. It is estimated that up to 50% of patients will have a moderate to severe medical course. The life expectancy of individuals with NF1 is reduced by up to 20 years, with excess of that in younger individuals that is less than 40 years of age compared with the general population. The most common cause of early death is malignant neoplasm. Individuals with NF1 have a 60% lifetime risk of developing cancer and are 4 times more likely to develop cancer compared to the general population. Especially their likelihood of developing malignant neoplasms in the nervous system, such as malignant glioblastoma and malignant peripheral nerve sheath tumor, are 40-fold and 1,000-fold higher, respectively, than that of the general population. The risk of low-grade tumors, such as optic pathway gliomas, is also significantly increased. And furthermore, NF1-associated breast cancer typically arises at a younger age, with the highest incidence in women under 40, where the risk is increased 5 to 10-fold, defining a moderate risk for breast cancer. So malignant peripheral nerve sheath tumors are rare soft tissue sarcomas, which are frequently arising from a pre-existing plexiform. They develop in up to 15% of NF1 patients and represent the leading cause of death in NF1. They are clinically aggressive and tend to metastasize early. The median age of diagnosis is about 30 years, which is 10 years younger than the sporadic counterpart. Awareness of known risk factors and clinical suspicion remain paramount for early detection of malignant peripheral nerve sheath tumors, which is facilitated by targeted MRI imaging or PET scans. Education of the patient about red flags is key here, and surgery remains the cornerstone of treatment for high-grade malignant peripheral nerve sheath tumors with the aim of achieving clear margins. The role of adjuvant chemotherapy and radiotherapy is also important. This image summarizes the current knowledge of the pathogenesis of malignant peripheral nerve sheath tumors. We have seen what leads to the formation of plexiforms. Afterwards, cooperating genetic alterations, such as, for example, P53 or SUS12 mutations, are required for the formation of malignant peripheral nerve sheath tumors. To illustrate another complication of NF1 is the history of one of our patients, a 42-year-old woman, was referred to our clinic by Dr. Fuchs. She had a previous clinical and laboratory diagnosis of Down syndrome. Her past medical history revealed café macules since birth and excision of a benign back mass with no follow-up. At age 40, she was diagnosed with stage 4 breast cancer. A multi-gene panel for breast cancer was done, revealing that she was a heterozygous carrier of an NF1 pathogenic variant. On physical examination, we found features of Down syndrome, as well as multiple café macules, bilateral skin fold freckling, and neurofibromas, including a plexiform neurofibroma below her left shoulder. This case illustrates not only that NF1 can co-segregate with other syndromes, but also the increased risk of women with NF1 to develop breast cancer. Note that T21 is considered to be protective towards cancer, but it's my unproven speculation that NF1 overcame this protection, making, in my opinion, this case more poignant. Women less than 50-year-old with NF1 have a moderately increased risk of breast cancer, which may present at an earlier age than in the general population, with highest risk between the age of 30 and 39. Predominant type is invasive ductal carcinoma, which is the most common subtype in the general population. Expert opinion-based guidelines recommend annual mammogram starting at the age of 30 and to consider breast MRI between the ages of 30 and 50 if there are suspicious features. There is currently insufficient evidence to support the use of risk-reducing mastectomies in women with NF1, although this may be considered based on a positive family history or personal history of breast cancer. This is another patient ascertained in our clinic. A 62-year-old woman known for NF1 syndrome with no active follow-up was diagnosed with stage 1 endometrial cancer. Immunohistochemistry of the tumor revealed absent expression of the PMS2 protein. On physical examination, she was found to have multiple caffeole spots and extensive neurofibromas. She was one of 6 daughters born to non-consanguineous French-Canadian parents. Her family history was significant for bile duct, breast, and high-grade serous ovarian cancer in 3 first-degree relatives, also known for NF1. She herself had 2 sons, both of whom were healthy. Molecular testing confirmed the diagnosis of both PMS2-associated Lynch syndrome and of NF1. What is interesting about this atypical scenario was that neither endometrial nor ovarian cancer have been previously described in females with NF1, and presence of this cancer prompted consideration of overlapping cancer predisposing syndromes. Also, germline pathogenic variants in the PMS2 gene account for only 5% of families with Lynch syndrome and are considered of low penetrance. It remains unknown whether in this particular case, the penetrance of a pathogenic PMS2 variant was enhanced by context of NF1 gene deficient microenvironment. And finally, consideration of the unique and overlapping phenotypes of NF1 and Lynch syndrome in this family was essential to providing appropriate risk assessment and tailored management for this patient. 2 more complications, one involving the skeleton and the other one is hypertension. As for skeletal anomalies, we know that musculoskeletal findings are frequent in NF1. Patients are generally shorter than expected with relative macrocephaly, suggesting a generalized skeleton bone growth decrease. The presence of a distinctive osseous lesion is one of the consensus diagnostic criteria in NF1. And the most morbid skeletal manifestations are focal lesions, such as, for example, dystrophic scoliosis and long bone dysplasia or pseudoarthrosis. These typically present in childhood, but can have lasting effects into adulthood. There is also evidence that both muscle and bone may be altered in patients with NF1. We sought to clarify the relationship between muscle development and bone metabolism in a population of children with NF1 followed at the Shriners. These children underwent forearm peripheral quantitative computed tomography in the non-dominant forearm, and findings showed that the bone mineral density of these children was below that expected in healthy individuals. The radius of children with NF1 and their forearm muscles were found to be smaller than expected, even after correction for height was done, suggesting that bone size deficit could be caused by inadequate muscle development. Results align with those obtained at lower extremities, indicating that the musculoskeletal disturbances in NF1 are at least in part independent from weight bearing. Now, several studies report an increased prevalence of osteoporosis and fracture rates in adults with NF1. Osteoporosis occurs at an earlier age and progresses over time, and it has been proposed that vitamin D deficiency contributes to osteoporosis in NF1. However, the impact of vitamin D supplementation in NF1 on bone density and fracture is unclear. Earlier screening with DEXA scans may be warranted in individuals with NF1, We tend to do that in clinic, but data are lacking. There are guidelines in the general population for initiation of bisphosphonate therapy based on DEXA values and clinical history using several fracture risk assessment tools. And then NF1 could be or should be entered as a risk factor when using such algorithms. Non-dystrophic scoliosis can also develop in adulthood, and its management consists of monitoring for curve progression and referral to orthopedics if concerned. Finally, hypertension is also commonly observed in persons with NF1, and its incidence increases with age. The most common causes of hypertension in NF1 are essential hypertension, renal artery stenosis, mostly in young adults, and pheochromocytoma. Up to 3% patients with pheochromocytoma paraganglioma may harbor NF1, and the incidence of pheochromocytoma in NF1 is about 6%. The incidence is higher at autopsy, and a study of 48 NF1 patients evaluated at hypertension clinic found that 15% harbored a pheochromocytoma. Of these, 57% were symptomatic at diagnosis. A study of 25 patients from a pheochromocytoma registry found a median age of presentation of 43 years with exclusively adrenal disease, that is no paraganglioma. About 20% were multifocal and 12% were malignant, a rate which is similar to that of sporadic cases. Individuals with NF1 may also harbor mixed pheochromocytoma and ganglioneuroma tumors. I think I preached to the converted here regarding the management of renal artery stenosis and pheochromocytoma, but just simply to say that it is by standard approach. One area where we advocate for patients here is to try and avoid as much as possible their exposure to radiation-based tests. So we favor MRI investigations to assess these issues. So what are the bases of the clinical variability observed in NF1? There are several reasons why NF1 is so variable in expressivity. One is the fact that the clinical manifestations of NF1 are age-dependent. Another important reason is that, as we have seen, neurofibromin acts as a tumor suppressor. As such, the genetics of NF1 follows the two-hit model of disease. Remember that each person has two copies of every gene. The first hit is a germline variant, that is a variant that happens in every cell of the body. This variant may be inherited from a parent with NF1, or it may happen for the first time in a person with NF1 at the moment of conception. The second hit is a somatic variant that happens on the other NF1 copy. So we can see this here. And the second hit happens randomly in different cells and in different parts of the body in different individuals, and is not hereditary. Additional explanations include modulation by other genes in the metabolic pathway of NF1, interaction between the two copies of the NF1 gene, and the effect that specific genetic variants may have on the phenotype. There is evidence that some genetic variants are associated with more severe symptoms and others with mild symptoms. To illustrate this point is the history of another patient, a young woman with familial NF1 and multiple complications of the syndrome, including a high-grade sarcoma in the left arm, for which she is status post-radiation therapy and surgery. On physical examination, in addition to the skin manifestation diagnostic of NF1, we also noticed coarse facial features and overgrown hands and feet. Genetic testing demonstrated a heterozygous carrier status for a total NF1 deletion. About 10% of patients with NF1 harbor whole gene microdeletions encompassing the NF1 gene and its flanking regions. These deletions are not picked up by sequencing and require a dedicated test for their detection. This is one of the most important genotype-phenotype correlations in the syndrome because already at a very young age, these patients frequently exhibit a severe disease burden, which requires specialized long-term clinical care. Importantly, individuals with NF1 microdeletions have a lifetime malignant peripheral nerve sheath tumor risk, which is double than the estimated lifetime risk in the general NF1 population. And also, these sarcomas occur significantly earlier in patients with NF1 microdeletions compared with NF1 patients with intragenic mutations. These images illustrate the characteristic facial features of patients with whole gene deletion, including hypertelorism and coarse facial features. These patients may also have overgrown hands and feet. and these are males with NF1 microdeletion. Thus far, only a few other genotype-phenotype correlations have been established, and more are emerging. Each clinically relevant genotype-phenotype correlation is rare and only applies to a small percent of patients, of individuals. Yet, taken together, they can impact counseling and management of more than 10% of the NF1 population. Another situation that may contribute to the clinical variability of NF1 is mosaicism. This refers to a localized and unusually mild form of NF1, which is due to two somatic NF1 mutations. This form of disease presentation is possibly under-recognized due to skin findings being atypical or sparse. It's about 10 times rarer than classical NF1, and patients are suspected to have mosaic NF1 on exam because typical skin findings are distributed to limited areas of the body. Due to possible involvement of testes or ovaries, individuals with mosaic NF1 may have children with classical NF1. Some individuals may even fulfill the diagnostic criteria of the classical form as they present with 6 or more cafeolate patches with skin fold freckling or neurofibromas. The importance of making the diagnosis is that NF1 complications are relatively infrequent in mosaic NF1, and there is a much lower risk of recurrence in children of patients. In people with mosaic NF1, genetic analysis of a cafeolate spot or of a neurofibroma may be necessary if the NF1 variant is not detected in the blood. So the indications for molecular testing in NF1 are becoming broader with increased understanding of the disease mechanism and availability of precision treatment. And in general, this should be considered in individuals with an unclear clinical diagnosis or in whom a definitive molecular diagnosis can guide surveillance and aid in prognosis. In 2018, the American College of Medical Genetics produced its first management guidelines for adults with NF1. They included recommendations for clinical management are derived by review of published management literature and the collective expertise of the authors. Tackled issues include malignancy, vasculopathy, bone health, burden of disease and cosmesis, neuropathy and pain, and reproductive issues. Management of patients is best done in a specialized clinic. In the past 5 years, a clinic like ours, in the past 5 years or so, more such clinics dedicated to the care of adults have cropped up throughout the country. The role of a specialized adult NF1 clinic is to diagnose NF1 in atypical or difficult cases, provide single point of expert clinical care, educate and support the patients and family and their families, monitor and manage complex disease, and provide a forum for clinical audit and academic interaction through multidisciplinary meetings and video conferencing. Our population of patients is well studied and monitored. Our management protocol adheres to and often exceeds the established guidelines for the management of adults with NF1. All patients are offered a baseline workup, and complex patients are followed up at closer intervals in collaboration with colleagues from our extended network of affiliated specialists. We also pursue several research venues. We're currently seeking to define the prevalence of psychiatric manifestation and the psychiatric phenotype of our population of adult NF1 patients regularly followed in our clinic. Few tools are available to assess for psychiatric issues in patients with NF1, but we know that many adults with NF1 are at increased risk for social, emotional, and mental difficulties. All these are still poorly studied topics. For example, the rate of autism and whether NF1 is associated with autism is unknown. Our preliminary findings suggest increased comorbidity for psychiatric disorders in patients with NF1 compared to the general population. And additional risk factors include developmental difficulties, ethnic background, sleep disturbances, and familial diathesis for psychiatric disease. About a third of patients have a complex psychiatric phenotype, and autism is often misdiagnosed or under-recognized. However, a formal psychiatric diagnosis allows rational treatment and facilitates access to community services. Findings of this preliminary overview suggest that all adult NF1 patients should be screened for psychiatric disease, and that those suspected to harbor psychiatric disease should be referred for expert management. Another aspect is pharmacological trials. Trametinib is a MEK inhibitor that had previously been approved for cancers harboring mutations in the MUHC pathway, such as, for example, melanoma. And as we have seen, the same pathway is activated in NF1 tumors. A phase 2 trametinib trial is coming to an end at the MCH. Primary objectives are to determine the response rate of trametinib as a single agent for treatment of progressing or refractory plexiform neurofibromas or optic pathway gliomas. Initial data show that the treatment is efficacious and well tolerated. Eligible patients receive daily oral trametinib at full dose for 18 months and undergo serial MRIs, ophthalmology, neuropsychology assessment. At least 25% reduction in tumor size is necessary to claim efficacy. And over the past 2-3 years, a total of 150 patients have been enrolled for the trial in 7 Canadian centers, including at the MCH, and the results are about to be published. These are the images of one of our pediatric patients who was enrolled in the trial. She has sporadic NF1 and developed a parotid plexiform neurofibroma, which showed rapid growth. This was associated with homolateral conductive hearing loss, leading to language delay. Post-trial, her plexiform decreased in size by about 10%, with improved hearing function from moderate severe to mild and language performance. Although not enough to call this a response, the patient received clinical benefit. Selumetinib is another MEK inhibitor developed by AstraZeneca for the treatment of NF1. It has been FDA approved for use in pediatric patients 2 years or older who have symptomatic inoperable plexiform neurofibroma. A phase 3 trial is about to start worldwide for treatment with selumetinib of adults with NF1, plexiforms, and pain. There's a huge recognition of the work we do and the patients we follow in our clinic. Our clinic has been selected as the Quebec site for the trial, one of only 3 sites in Canada. And finally, the development of cell-free technologies which monitor fragments of DNA released by dividing and dying cells into the bloodstream offers another extraordinary venue of research in NF1. 2 such studies led by Dr. Kim and Dr. Pugh in Toronto explore an integrated approach to cell-free DNA analysis. This project will focus on recruiting patients with NF1 across Canada with the objective to develop a comprehensive and sensitive blood-based analysis for the early detection of cancer. Briefly, cell-free DNA is physiologically released and is found in plasma. Tumor cells can also release DNA in plasma, and by analyzing cell-free DNA, we can detect all sorts of cancer-associated genomic variations. These include genomic copy number variations in the plasma that reflect those in the tumor, determination of DNA fragment size, position, and coverage across the genome, and this shows that tumors in general release shorter fragments compared to healthy cells. Likewise, malignant peripheral nerve sheath tumors are associated with an increased proportion of short fragments similar to other sporadic cancers. This information can be used to track patterns and profiles in the blood to help determine when a plexiform may transform into a malignant peripheral nerve sheath tumor. And this particular technique capitalizes on the unique tissue and cancer-specific methylation signatures that are conserved on plasma DNA to detect cancer-specific methylation signatures. Fragments of DNA released into the plasma are marked with methylation, which is determined by the cell type which releases it. And the plan is to build malignant peripheral nerve sheath tumor methylation data and trap this in the blood of patients with plexiforms to see if there is evidence of malignant transformation. So we're looking at all these different tools to try and improve and simplify the diagnostic process of patients with NF1. In summary, I hope that I was able to convey the message that precision medicine in NF1 begins at diagnosis. In fact, the diagnosis of NF1 sets in motion a lifelong surveillance plan to identify medical issues that would not otherwise be anticipated in the general population. Thus, making a diagnosis of NF1 is an example of personalized medicine at its best. It alters the management and directs the care of patients. It's important to keep in mind that patients with NF1 may enter tertiary care through one or more specialized doors. It could be your doors, and that a diagnosis of NF1 may coexist with other unrelated medical conditions. Specialized clinic like ours function as the medical home of these patients And in these clinics, coordination of care and facilitated access to research study and clinical trials happen. Further research is needed to address unanswered questions about the natural history and management of this syndrome. And we believe that the NF1 MUHC Adult Clinic is well positioned to contribute to advances in research and care for patients with NF1. And this concludes my presentation.
Thank you very much, Dr. Daniela D'Agostino. Thank you, and congratulations really on being able to set up such a great example of a clinic across the lifespan that you have here at the MUHC, and presumably being in one institution with both pediatrics and adults has facilitated that, I imagine. We have a few questions coming in, so we'll start with some of the questions. Luis Pilar would like to know, how does one handle statistical power in trials in these low volume type of patients? How do you do that?
Well, one way to, I don't think I have a strong answer to this, but one way to tackle this, well, first of all, NF1 is not, is what I call a common rare disease. So the numbers are not as small as for other rare diseases. But one way to tackle this is to actually come together as a community of physicians that follow these patients, and to try and increase the power of our observations. And in Quebec and across Canada, we're very fortunate because in the past, I would say about 6 years, when I started, building up this clinic, it has been a moment where interest in NF1 has, in care of adults with NF1 has increased. And so there is a lot of initiatives that are being brought forward. And the community of physicians caring for these patients is coming together. And I think that's a way around it.
Along the same lines, what are the endpoints in these rare genetic disorders? When you do clinical trials, what are the endpoints you're looking at?
So for, well, I can say about the selumetinib trial, we're looking at reduction of the size of the plexiform. And as we have seen, a reduction of about 25% of the size is considered a response. And the patients will be stratified also for reduction of the pain that's associated with plexiform.
Okay, perfect. Daniela, how does one refer to the specialized clinic? Is there a similar resource for NF2?
That's a good question. I consider myself an NF1ologist or a RAS pathway specialist. So I don't follow patients with NF2. The people that would assess patients with NF2 are the MNI. I would definitely refer patients with NF2 to Dr. Eber-Bluen, who is one, probably the only neurosurgeon specialized in taking care of peripheric nerve tumors. But there is also a team that cares for central nervous system tumors. But for the NF1 clinic, you just have to refer to genetics, and you have to indicate that patient is suspected to have NF1, and all these patients are directed to my clinic. And then they are managed, as I said, the simple ones, they are assessed in clinic, and we follow them at intervals of 1 to 2 years. Those that have more complex presentation are assessed together with Dr. Eber-Bluen and other specialists, including many internists that follow these patients for their associated problems. So we do a lot of coordination of care in reality.
Okay, we have another clinical question for clinical trials. Is there a placebo control in any of the clinical trials?
The selumetinib trial, there is a placebo arm that will last for 6 cycles at the moment, and then the patient will be, all patients will be enrolled into taking the medication. For the pediatric trial, there is no placebo, as far as I know.
So Dr. Fantis, thank you. Dr. Fantis wants to know about the activated RAS in NF1. It activates RAF and then MEK. What are the RAF inhibitors being? There are RAF inhibitors being used to developed for cancer. Have these been tried and tested in NF1 tumors? Do you know anything about that? The RAF inhibitors, RAF inhibitors?
I'm not aware of those.
Okay, and another question here, excellent rounds. This is from Tina Podimau. I have a very dear patient, NF1, whom I follow for hypertension. Can you comment on cognitive development of this population?
That's a very good question. Well, we talked about the psychiatric manifestations. In general, patients with neurofibromatosis type 1 are of normal cognitive function, except for those that harbor the whole gene deletion and the micro deletion. Those are usually of lower borderline cognitive function. What kind of impact on the function of these patients that they have there is a very high prevalence of conditions such as attention deficit disorder and various learning disabilities. So these patients manage, they function through life, but they carry from childhood these difficulties. The other thing is, it's not very common, but there seem to be an increase in some patients with NF1, a very small group, may be more prone to cognitive deterioration in adulthood, such as, for example, dementia. And I just have one patient like this, and he's being now studied in the aging center by Dr. Pedro Rosaneto at the at McGill. So we try to see, like we said, we function as a point of care for this patient, trying to also hook them up to all the venues that the MUHC and McGill has to offer, for their specialized care.
Just a question for you with respect to that. So you follow pediatric, you follow the patients through their lifespan in one clinic. So you don't have to worry so much of transition of care. But when they have specialists, the specialists are different in pediatrics and adults. So I'm just curious how you navigate. Most of us, the patients get transferred, chronic care patients get transferred from the children to adult care. There's kind of a transition period and everybody changes. You just have one team that changes, right? I mean, you have one fixed team, and I'm just curious how you find that works. Is that a model that you would recommend?
I think this is a fantastic question, and I always say that, like we said at the beginning, that the NF1 clinic and perhaps other clinics in our genetics division really embody the call of the MUHC to follow patients across the lifetime of the patient. There was we had an assessment of our division a few years ago, and this assessment, it was called by the Department of Pediatrics, recognized that some disciplines, like for example, medical genetics, are valuable bridges, medical bridges for patients that are transitioning from the pediatric to the adult care, exactly because of what you said, that we span the lifetime of a patient. So what happens, I can't wait in clinic, part of me can't wait to take these patients in when they become adults or to continue following them, because I know that I can rely on the specialized medicine resources that are appropriate to actually make sure that their care is continued. And I have to say that these patients are usually nicely welcomed in the adult milieu of the MUHC. So we take them in, and then we slowly rebuild that network of specialists that they may need in adulthood. Some conditions improve or become under control with age. For example, the optic pathway gliomas, even if they are there, they usually become quiescent they don't, let's say, cause problems. But we, for example, we attach the patients to the MNI if needed, or to various specialists at the gland.
Perfect. Thank you so much. And I see a comment from Dr. Rosenblatt here that the training also in medical genetics involves exposure to patients across the lifespan. So it's quite unique in terms of that model of patient care and patient and training. So I think we're gonna end there. We've had a lot of questions, and I thank you for answering all the questions. Thank you very much for presenting today. Excellent, really a very interesting topic, and congratulations on setting up this clinic and all the work that you're doing and the advancement in this particular patient area. So I wish you good luck. Thank you so much.
Thank you, and refer the patients.
Thank you. Bye-bye.
Bye.